You're listening to This Week in Cardiology from theheart.org, Medscape Cardiology. This podcast is intended for healthcare professionals only. Any views expressed are the presenter's own and do not necessarily reflect the views of WebMD or Medscape.
You can now access the latest in medical news on your Amazon Alexa-enabled device. Join me, Perry Wilson, every weekday morning for Medscape Medical Minute, where I highlight the top medical stories of the day. To add Medscape Medical Minute to your flash briefing, search for Medscape Medical Minute on Amazon and click Enable. Or open the Amazon Alexa app, go to Skills, search for Medscape Medical Minute, and click Enable. Then say, Alexa, what's the news? Or Alexa, what's my flash briefing? I hope you'll join us.
Hi everyone, this is John Mandrola from theheart.org, Medscape Cardiology, and this is This Week in Cardiology for January 13th, 2023. This week, I'll cover the FOURIER author's response to last week's BMJ Open article, a possible practice-changing paper in cardiac pacing and electrophysiology, a lesson in biased trial design, and the CAPLA study is published. First up is the FOURIER reanalysis. Last week, I reported on a provocative paper in the BMJ Open journal which reanalyzed death outcomes in the placebo-controlled FOURIER trial of the PCSK9 inhibitor evolocumab. Now, the authors, who are part of a group called RIAT, R-I-A-T, Restoring Invisible and Abandoned Trials, they got interested in the FOURIER trial because the 27,000 patient trial showed a massive reduction in LDL cholesterol with evolocumab, and this was in high cardiovascular risk patients. But that degree of LDL cholesterol reduction only led to a 15% reduction of a composite primary outcome. But CV deaths and overall deaths were actually numerically higher in the evolocumab group. So the authors were also struck that most of the CV deaths in the trial were labeled as quote-unquote other CV deaths, not as MI or CHF related, which typically predominate the CV death category. And with much effort, the authors got hold of the clinical study reports, which included details on the efficacy and safety events in the trial, and they found that there were substantial disagreements between what the local investigators in FOURIER reported as deaths versus how the clinical events committee adjudicated them. And in the adjudication of the BMJ authors using the clinical study reports, they also found higher rates of CV death in the evolocumab group, though it still did not reach significance. But their hazard ratio was 1.20 or 20% higher, and the upper bound was like 50% higher. So, in my opinion, though, the BMJ authors overreached in their conclusion because they stated that their reanalysis should cause clinicians to be skeptical about prescribing evolocumab. Last week on the podcast, I offered two options. One was that this was a much ado about nothing because the main trial results were still upheld, and also the CSR reports offered less information than what the clinical events committee had during the trial. But the other option that I offered was that there seemed a lot more flux in the trial reporting than I would have expected, and that this reanalysis at least raised the possibility that this cholesterol-lowering drug may have off-target effects that reduce its CV protective actions. What's more, I thought the reanalysis argued for more independent and transparent review of major practice-changing studies like FOURIER. Well, this week, the TIMI study group at Harvard wrote a letter of response. First author was Mark Sabatine, who was the PI of FOURIER. Let's just say this was a strongly worded response that included many strong modifiers, in which the authors rebut the claims of the reanalysis and have confidence in their trial reports. And I would encourage everybody to read their letter. It's short and it's also on an open journal, which is nice. I found their letter to be pretty persuasive. Now, some experts have called this whole thing a waste of time. The TIMI letter concludes by saying that this is a gross disservice to the medical literature, clinicians, and patients, And, that may be overreach as well. Dr. Sanjay Kaul, who's often cited in these kinds of situations because he's an expert in critical appraisal and regulatory matters, he had a worthy comment at the end of the Heart.org Medscape Cardiology news piece. Here's what the paragraph said. FDA's response not to provide the data was, quote, rather curious. And Kaul said that 17 and colleagues had the opportunity to address the RIAT group's concerns, but the paper notes that they did not even bother to respond to emails. Quote, you can't be holier than thou in medicine. You have to treat every question with respect and humility, and you can't be dismissive. Kaul says he could have nipped the evil in the bud, so to speak. Now, I'm drawn to Kaul's comment because I see it as important that we move to a more open and transparent system of science adjudication. And let me give you another example from 2022. This is an example that may have flown under your radar. There's a neurologist at Loyola called Ravi Garg, G-A-R-G. He published 2 papers last year that called into question the validity of major thrombolytic trials for acute stroke, and I'll link to both these peer-reviewed papers. One paper was a survey of missing data in the seminal meta-analysis of alteplase for ischemic stroke and RCTs. Garg found that the number of participants lost to follow-up was greater than the fragility index in the chosen meta-analysis and individually positive components of the RCTs. And this missing data may impact the direction of the reported effect or effect size. Now, another of Dr. Garg's reanalysis, this one of the seminal NINDS, N-I-N-D-S trial, that started the whole thrombolytic for acute stroke paradigm. Garg found that the famous baseline imbalances in that trial were more likely due to randomization errors than just random chance, and that when he adjusted for these baseline imbalances, he found a reduction of treatment effects. And these findings, he wrote, strongly suggest the possibility of selection bias. Now, I don't want to get into the weeds of stroke care. I've already done that, and it's quite scary how weak the evidentiary support is for such an established dogma. My point is that it's a little late to be doing such independent reanalyses. I'd propose a world where these sorts of things, questions on outcome adjudication, questions on randomization errors or missing data, are dealt with at the time of regulatory approval. That's before therapeutic fashions get established. Now, you may disagree with this whole analysis, and please let me know in the comments or on Twitter or anywhere else. Second topic today is a really important, potentially practice-changing paper in my field of cardiac pacing and EP. A group from Israel, first author Morris Topaz, senior author Sami Viskin, has published their 14-year experience treating infected device pockets without extraction. That's right, it's not me misspeaking. This technique is called continuous in situ targeted ultra-high concentration of antibiotics, and they abbreviate it CITA. Before I tell you about this study, I want to set out how shocking this is. It's shocking because one of the most solid dogmas in all of EP has been that the only solution for infected devices is a total system extraction. And this can be a serious problem because some patients are very difficult to extract. They may be frail. They may have very old leads. These leads get scarred in place. They have many leads that may be bound up together in the chest. Or the center that they're at may not be an experienced extraction center. Now, the Journal of American College of Cardiology, JACC, has published this important paper, which included 2 study types. The first was a descriptive case series, and the second was a case control, non-randomized comparison of the CITA technique versus standard lead extraction. The series included 80 patients, and get this, 85% of these patients with pocket infections were cured with CITA, and their follow-up was as long as 3 years. And in the case control study, where they compared the 2 techniques, cure rates were higher after lead extraction than after CITA. It was 96.2% versus 84.6%. However, the rates of serious complications were also higher after lead extraction. Now, a word on this technique of CITA. They first get cultures from any dehisced wounds of the pacemaker or at the time of surgery. Staph aureus patients were mostly excluded. Patients who had systemic infection like fever and endocarditis, these patients were excluded. These were patients who presented with localized pocket infections that we see often in our world. Okay, then the patient had extensive debridement surgery. You remove the pacemaker capsule, you debride the wound edges, then they clean the pocket with hydrogen peroxide and povidone iodine. Then they put an indwelling catheter inserted into the pocket in which they can give high-dose antibiotics, and the idea is that they get a standard full-dose antibiotic, but it's all in the pocket. There's so much antibiotic in the pocket that you can actually measure levels of the antibiotic in the body, but most of the drug is in the pocket. And then they put a negative pressure vacuum system dressing on it to let it heal. Now, the cultures that they were dealing with, a third of the time this was coag-negative staph, a third of the time a smattering of others. Professor Ann Curtis from the University of Buffalo wrote the editorial, and she wrote that this was a, quote, promising approach, one that offered patients a potential choice in therapy. She also noted the limitations, and that was that only 6% of the patients in the series had Staph aureus, but Staph aureus is a very common pathogen. For now, she points out that device extraction remains the only definitive treatment for device infections, but this study was a first step. And she also emphasized that identifying patients for whom this approach is not appropriate is going to be key, and this is really important. I agree with her. Here is why. Most hospitals in the U.S. do not have an expert extraction center, and in such centers, there'll be a strong temptation to extend this therapy to patients who should be referred out for extraction, and we have to be careful about that. We have to really keep in mind that these were a select group of people with localized pocket infection. But for a patient with 25-year-old leads, the chance of cure without the potential of SVC tearing during an extraction or possible death from extraction, this is a potentially big advance. I say congratulations to the authors and to the JACC editors for publishing such an important paper. Now, one final note. Device infections are one of the most catastrophic things that happen in electrophysiology. They most often occur after generator changes. Now, being older, I'm older, it teaches you some tricks to avoid such infections during generator changes. One I've learned is to debride the capsule and make sure that the new device is sitting properly in a new pocket and is not putting pressure on the skin. So that's a surgical thing. But the other is more important. The other thing I've learned is to see the patient in clinic beforehand and have an earnest discussion on the benefits and harms of not doing the surgery at all. Yes, that's right. Some patients with pacers hardly pace at all. Sometimes you don't have to replace it. Many patients with ICDs no longer garner significant net benefit from the device because of progression of their disease, for instance. If you can avoid replacing the generator, you avoid the risk of infection and possible extraction. All right, third topic is the ATLAS trial. Now, my friends, when I discuss this trial, I am going to pretend that the PI, Professor Jeff Healy from Canada, is in the room. I'm going to be very critical, Jeff, but it's not personal. I'm sorry, and I will buy you a coffee at the next meeting. I want all my listeners to bookmark this trial. This was a comparison of two defibrillators. I want to bookmark it as a classic example of a doubtful choice of endpoints and the strong possibility that marketing played a role in the study design. Now, at its core, this podcast aims to teach critical appraisal in a skeptical, not cynical way. The ATLAS trial highlights the bias inherent in trial design. Well, Stanford professor John Mandrola famously wrote about how most bias in medical studies comes before the first patient is randomized. So here's the story. We have this big debate in EP about the choice of ICDs in patients who are at high risk of VF and sudden death. In fact, the doctors in Buffalo caring for Damar Hamlin may have to decide between these two types of ICD. The standard transvenous ICD involves placing a lead into the heart for sensing, pacing, and then defibrillation if needed. Now, these devices are highly effective converters of VF, and they've been shown in multiple clinical trials to extend life in selected high-risk patients. Transvenous ICDs are tried and true, but their Achilles heel is that there can be lead problems, especially over time. Now, lead problems that occur a decade later can be super problematic because we just talked about extraction can be hard and risky. And consider a 30-year-old patient with a standard ICD is going to be facing many generator changes and the possible chances of lead revisions and/or extractions. So enter the subcutaneous ICD. Its potential advantages are that there is no hardware in the heart. The lead sits outside the ribs, close enough to the heart to sense the heart activity and also defibrillate the heart. The hardware, the generator, sits in the left side of the chest under the axilla. The potential advantages all stem from not having a lead through the tricuspid valve and inside the heart. But the Achilles heel of the SICD is that not having a lead in the heart poses challenges for both sensing and defibrillating the heart. And the SICD requires exquisite attention to detail regarding implant techniques. You have to get it super close to the ribs. And the SICD has never been tested in long-term clinical trials that looked at mortality outcomes. It was approved because of defibrillation testing alone. The ATLAS trial sought to compare the two devices. The outcome chosen was not long-term lead complications, it was not mortality, but it was perioperative lead-related complications. And with zero surprise, the SICD crushed the transvenous ICD. In this trial of more than 500 patients, only one patient in the SICD group had a primary outcome versus 12 in the transvenous ICD group, and this 4.4% absolute risk reduction easily met statistical significance. The SICD had 2.4 times more inappropriate shocks. That was a trend that nearly made significance, and there was also slightly more reports of pain at the ICD generator site in the SICD group. The authors concluded, quote, the SICD reduces perioperative lead-related complications without significantly compromising the effectiveness of ICD shocks. The paper was published in the Annals of Internal Medicine, which is curious because why not a cardiology or EP journal? Now, when this was presented last year, the very next day, Boston Scientific, the maker of the SICD, had advertisements go up on social media that included superiority of their SICD. Now, so far, you've probably not detected anything too interesting. Let me tell you the punchline. The punchline is the choice of the primary endpoint. The primary endpoint chosen was a composite of pneumothorax, cardiac perforation or tamponade, lead dislodgement that required revision, new tricuspid regurgitation, or an upper extremity DVT. So let me just pause there so you can think. Okay, the industry-funded trial had a composite primary outcome that included 4 of 5 components that could not occur in the SICD arm. So by design, you don't get pneumothorax, tamponade, tricuspid regurgitation, or vein occlusion with the SICD. So this is why you keep this study bookmarked. You keep it because I can find no better example of a trial designed to show one arm will win. And the question remains is when to choose between these two devices. This RCT of 544 patients enrolled in the trial doesn't inform that question. Now, I've previously discussed the other trial in this space called the Praetorian trial of SICD versus transvenous ICD. This was a non-inferiority trial that found that the SICD was non-inferior to the transvenous ICD. But that trial was also marred by biased adjudication of primary outcome events, and I've co-authored a letter to the editor of New England Journal of Medicine, which they published, that explains these issues. Okay, next topic is the CAPLA trial. JAMA this week published a very important trial in the atrial fibrillation and atrial fibrillation ablation space. The CAPLA trial took patients with persistent AFib, now that's the tougher kind compared to paroxysmal, who were going for ablation, and they randomized them to standard pulmonary vein isolation or pulmonary vein isolation plus left atrial posterior wall isolation. Now I'm going to try and keep this interesting for the general audience and not get too EP specific. The background is that we have established that electrically isolating the muscle bundles within the pulmonary veins is the standard lesion set for AF ablation. Don't ask me why we think this, we don't really know. But in general, PVI has been shown to work as well as PVI plus any other ablation strategies. But there have been very eminent experts who believe that extending the ablation so as to isolate the posterior wall of the left atrium between the right and left pulmonary veins is also an important thing to do. Their reasoning is that the pulmonary veins share an embryologic origin with the posterior wall, and smaller, methodologically weaker studies have suggested that posterior wall isolation improves outcomes over PVI alone, especially in patients with persistent AFib who tend to have more advanced structural atrial disease, but not always. Now, what makes CAPLA so perfect for the TWIC podcast is the method the authors used to answer this important question. They didn't use eminence, though they are eminent. They didn't report case series or non-randomized observational comparisons that we see so much in other sectors of medicine, especially recently infectious diseases. They did a randomized controlled trial. The choice of therapy was determined by random chance, and this leads to balancing of confounders. Now, unlike the ATLAS trialists, they measured a primary outcome that was relevant to both groups, and that is basically AFib recurrences. And they found and published that there were absolutely no differences in AFib recurrences. Procedure times were 20 minutes longer in the PVI plus posterior wall group, but there were no differences in safety outcomes. And they concluded that, quote, these findings do not support the empirical isolation of the posterior wall for ablation of persistent AFib. Okay, my comments. This finding is in line with the seminal trial called STAR-AF2, which also found that in patients with persistent AFib, PVI alone performed as well as PVI plus additional ablation outside the PVs. And these CAPLA results add to the field because it tempers the natural tendency in doctors that more is better when dealing with patients with more advanced disease. The idea for AF ablation goes like this. PVI basically, and I'm making it simple, but basically it stops the premature atrial beats from initiating AFib. PVI is a strategy for targeting drivers of AFib. But in patients with persistent AFib, that's unlikely to be enough because these patients may have structural or electrical disease that can perpetuate AFib. So PVI alone won't work, goes the thinking. But CAPLA, along with STAR-AF2, shows that less is as good as more. And this is a great finding because I hate burning on the posterior wall, and that's because the most feared complication of AFib ablation is thermal injury to the esophagus, and the esophagus sits right behind the left atrial wall, which is often thin. If you hurt the esophagus, it can lead to death. And remember, these are youngish people with a usually non-life-threatening disease. I will use CAPLA to not be tempted to use posterior wall isolation on the first ablation attempt. But now, just a couple notes on the nuance. There's always nuance. Proponents of posterior wall isolation have good points, and the editorialist, Dr. Rod Passman, pointed some of these out. Proponents will say it's hard to properly isolate the posterior wall, and if you don't do it properly, it can recur. Now, this is hard because of epicardial connections and thick tissue on the roof, and also you don't want to be too aggressive near the esophagus. But if posterior wall isolation is done properly, it may be durable, and durable isolation may indeed lead to better outcomes. The proponents will also say the new ablative technology called pulse field ablation, PFA, is going to work better for posterior wall isolation because you can ablate there without damaging the esophagus. PFA happens to be cardioselective. It doesn't affect the esophagus. Now, all these things are true, but regular listeners know what comes next. What comes next is the onus of proof remains on the proponents to show us a group of patients for whom posterior wall ablation succeeds in an RCT format. So that's it for this week in cardiology. As always, I'm grateful that you listened. Thank you. And remember, friends, if you like this podcast, please take the time to give us a rating on the app that you use. Even a 1 or 2 sentence review goes a long way to helping others find us. Until next week, this is John Mandrola from the heart.org Medscape Cardiology.
You're listening to This Week in Cardiology from theheart.org, Medscape Cardiology. This podcast is intended for healthcare professionals only. Any views expressed are the presenter's own and do not necessarily reflect the views of WebMD or Medscape.